Hello everyone, this session is titled Coping Strategies for Drug Endangered Children During COVID-19. My name is Hala Alazzawi and I serve as the Community Engagement Coordinator at the Detroit Health Department. I have a bachelor's degree in Sociology and Women and Gender Studies, as well as a minor in Arab American Studies. I come from a predominantly Arab American community in the city of Dearborn. I discovered my passion for alleviating health disparities in my second year of university when my professor told me to advance social change in an area that I am passionate about. Originally, I wanted to focus on disability advocacy as I have lived with a physical challenge for my entire life. However, when I noticed that a significant amount of youth were dying from overdose in my community, I became motivated to broaden my focus to encompass behavioral health. This motivation further propelled my commitment to ending the stigmatization of mental health and substance use. So today, I will be including information that is specific to the Arab American community. I would also like to please remind you all to complete the post-evaluation training to earn a certificate of completion. You will need to enter a personal code in the evaluation form, which is your mother's first initial, your first initial, and then your mother's birth month and day. 313 HOPE is the name of our behavioral health program. 313 HOPE provides free education, training, and connection to behavioral health services for individuals and loved ones dealing with trauma, addiction, or mental health issues. 313 HOPE also spotlights community organizations, programs, people, and events that are committed to promoting pathways to healing. The Trauma Training Series is part of the Building Communities of Recovery Initiative, also known as BCOR, in partnership with the Detroit Recovery Project and the Detroit Health Department. The purpose of BCOR is to support and empower people and organizations who serve the recovery community and to help individuals on their path to complete wellness. The BCOR initiative provides continuing education and peer support for allies in the health system and neighborhoods. Today, we are going to define drug endangered children and learn a little bit about the DEC movement. Then we will discuss how COVID-19 has exacerbated community stigma and health disparities for the Arab American community. Before we transition to the connection between adverse childhood experiences and mental health, we will briefly distinguish between primary, secondary, and tertiary trauma. And then we will conclude by going over coping strategies and trauma-informed methods to support DEC through the use of culturally sensitive services. A little bit of a disclaimer. We will be covering topics such as adverse childhood experiences and types of trauma. So if you feel the need to step away from the computer monitor to take a wellness break, please do. Now we are going to jump into DEC and the movement. According to the Federal Interagency Task Force for Endangered Children, a drug endangered child is a person under the age of 18 who lives in or is exposed to an environment where drugs, including pharmaceuticals, are illegally used, trafficked, diverted, possessed, and/or manufactured, and as a result of that environment, a child is more likely to experience the following: physical, sexual, or emotional abuse, medical, educational, emotional, or physical harm, including harm resulting or possibly resulting from neglect, as well as being forced to participate in illegal or sexual activity in exchange for drugs or in exchange for money likely to be used to purchase drugs. Stemming in part from the methamphetamine crisis, the Drug Endangered Children, or DEC movement, began about 2 decades ago to respond to the growing phenomenon of finding children living among the squalor of meth labs located in homes and other areas where children were living and playing. The children found in these situations were often severely harmed or neglected, and in many cases, tested positive for drugs. To rescue these children, local DEC programs were created all over the country, and a national DEC program was created in 2003. Around the country, the DEC movement has rescued thousands of children and led to the development of numerous programs that have coordinated the efforts of law enforcement, medical services, and child welfare services to ensure that drug endangered children receive the appropriate care and attention. However, there is still a lot of work to do, and the pandemic has posed new challenges with identifying at-risk children. The graphic at the bottom of the page is a timeline of the history of meth created by the Nova Recovery Center. There are two major programs that launched as a part of the DEC movement: the Drug-Free Communities Program, or the DFC, and the High Intensity Drug Trafficking Areas Program, referred to as HIDA, which I will expand on shortly. The Drug-Free Community Support Program, or the DFC, was created by the Drug-Free Communities Act of 1997, is the nation's leading effort to mobilize communities to prevent youth drug use. It is directed by the Office of National Drug Control Policy, or the ONDCP, in partnership with the Substance Abuse and Mental Health Services Administration, or SAMHSA, and provides grants to local drug-free community coalitions to increase collaborations among community partners and to prevent and reduce youth substance use. Additionally, there are a few programs that I would like to highlight that provide resources for DEC. CADCA, or the Community Anti-Drug Coalitions of America, the Love Detroit Prevention Coalition, or the active coalition that influences outcomes in the neighborhood, and the High Intensity Drug Trafficking Areas, or HIDA program, was created by Congress with the Anti-Drug Abuse Act of 1988, provides assistance to all levels of government and law enforcement agencies operating in areas determined to be critical drug trafficking regions of the United States. The purpose of the program is to reduce drug trafficking and the production in the United States by facilitating cooperation among various agencies to share information and implement coordinated enforcement activities. DHD, in partnership with U of M and HIDA, launched a system for opioid surveillance, which provides near real-time suspected opioid overdose data. We use this data to inform our outreach strategy, which includes training and distribution of naloxone, or Narcan. Now that we've delved into the historic aspect of the DEC movement, we are going to dig into the social, financial, and cultural obstacles that Arab Americans face when accessing treatments for DEC. Additionally, we will explore how COVID-19 has compounded health disparities within the Arab American community. One of the most crucial things to think about when providing care to DEC in the Arab American community is cultural sensitivity. We need to develop an awareness of how to develop resources that are more language appropriate in order to reach a wider audience of the Arab American community. The Substance Abuse and Mental Health Services Association, or SAMHSA, has implemented the Culturally Linguistic Appropriate Services Program Initiative, or CLAS, in order to provide more culturally and linguistically diverse resources to various communities. While SAMHSA provides a wide range for resources for various minority groups, such as Hispanic, Pacific Islander, and disability populations, they do not appear to offer any resources for the Arab American population. The reason for this is that Arab Americans have been historically classified as white or Caucasian in the US Census. This classification has hindered the Arab Americans' population's access to culturally linguistic materials and resources as a result of insufficient data. Thus, there is a limited range of resources that families of drug endangered children can benefit from. So, I, as an Arab American woman myself, I know how frustrating it can be to be classified as white, particularly when trying to access a service that does not have culturally linguistic appropriate resources. Not, for example, immigrants who have recently arrived in the US and have limited and are not and have limited English speaking skills may struggle to access resources that are relevant to them. I know that in some families and in some cultures in the Arab American community, women may prefer to access healthcare services that are provided by female healthcare providers, and a lot of the time that's not available. So we need to develop more culturally linguistic services to ensure that these women feel safe and comfortable opening up to their healthcare providers about their health needs. We also need to understand that it's crucial for behavioral health professionals to establish a more comprehensive understanding of how to meet the needs of the Arab American community through more culturally sensitive approaches. So I encourage some of you listening to think about what changes we can make as a society, and maybe think about what would you like to see differently. So now, on top of the linguistic and cultural barriers that challenge access to inadequate treatment services, DEC and the Arab American community were already extremely vulnerable because there's another layer of threats brought on by the coronavirus pandemic. Research by Nadia N. Abulazam from PubMed 2020 has shown that the COVID-19 pandemic has amplified the lack of resources for the Arab American community through the following ways. One of these ways includes xenophobia. Since the 1800s, Arab Americans have experienced hate crimes, discrimination, and racism. These oppressive structures have increased health disparities for Arab Americans. I remember when I was younger, in the aftermath of 9/11, many of us were told not to speak Arabic in class or in school. I remember having to translate for Arabic speaking students, and I couldn't because I was told not to try not to speak Arabic, and I was discouraged from it. Another factor to think about, another factor that Abdul Azam mentions in her article includes underlying health conditions. Arab Americans have a higher risk of diabetes, hypertension, and obesity than other populations. For instance, in some samples, Arab Americans are more likely than white people to be at risk for diabetes by 23%, In addition, research shows that Arab American women are 4 times more likely to report being diagnosed with heart diseases than Black women. Furthermore, another hospital in Michigan found that the hypertension was more widespread in Arab American men than it is for white non-Hispanic men. Living conditions. The family dynamic of Arab Americans may contrast with those of non-Arab populations, as Arabs tend to rely on or hold importance to connections to family members. Thus, a higher chance that Arab Americans there's a higher chance that Arab Americans living with family members may be at risk for transmitting the virus to older family members. This factor connects to COVID-19, as there is a higher risk for transmitting the virus to elderly family members. Another factor to consider during the coronavirus pandemic, or another factor that exacerbates disparity, is social support. Recent research based in Canada showed that first-generation Americans have more negative health outcomes than second and third-generation Americans, or I should say the lack of social support. I apologize. So the lack of social support. Recent research in California showed that first-generation Arab Americans have more negative health outcomes than second and third-generation Americans. This is a challenge that can be overcome with more effective outreach strategies and widespread resources in the Arab language. Preventative behavior. Arab Americans struggle with utilizing preventative care services. I will detail this point later in the slides. Therefore, there needs to be more educational services designed to spread awareness about preventative care to a wider audience of Arab Americans. These factors make it difficult for DEC children to be more vulnerable, and make them more vulnerable, as internalized xenophobia and lack of social support may discourage Arab Americans from providing their children with the care they need. Furthermore, this may pose an additional layer of risk on DEC, as these issues may isolate them even further and dissuade them from getting the person-centered care that they need. Now that we've identified a lack of culturally sensitive services and health disparities compounded by COVID-19 as high-risk factors, we will explore the ways that stigma within the community may delay the healing process for DEC. Furthermore, there are factors for behavioral health professionals to think about when thinking of how to help DEC in the Arab American community. These factors may be, but are not limited to, denial from the family or the community that the child is struggling. Family members may try to dismiss or minimize the impact of the struggle in order to avoid stigmatization from the community. Many youth may be afraid to access health services for fear of being otherized or stigmatized by their fellow community members. Accessing resources even when uninsured. Family members who would like to access services for their child may not have enough resources to access treatment. There are youth in the community also and families who would like to access resources for their children, but they don't have enough financial resources. Also, secrecy. In some cases, children may fear that their parents have too many challenges to deal with. Thus, they may feel even more isolated and less inclined to express their concerns to the family. Youth may feel like their parents are going through enough challenges at home, so they may feel like talking to their parents may exacerbate or worsen the situation. Finally, language barriers. Going back to the lack of widely available language resources for the Arab American community, there is also a major barrier when trying to access healing resources for drug endangered children in this community. This challenge is particularly exacerbated for Arab immigrants who recently arrived in the U.S. but speak limited English. These immigrant groups may be attempting to access services, but may be discouraged if they are only near agencies that may not offer resources in Arabic. Relating this to a personal challenge that my mother faced, I oftentimes, like sometimes my mom would be trying to access a health service and they would have no Arab translator, so I would have to translate for her. Now, there are certain first generation Arab Americans who don't speak fluent Arabic, and I acknowledge that if I was someone who was not fluent in English, if I was the daughter of immigrants who was not fluent in Arabic, pardon, I would face a challenge trying to translate for my mother, and she would face a challenge trying to access those services. So this is very important to consider when wanting to provide services and incorporating inclusion in these services. Despite these significant obstacles that are brought about as a result of stigma, there are 3 factors that we must consider when offering healing resources for DEC on an individual, organizational, and community level. So on an individual level, we have to consider language, relationships, honesty, and authenticity. We have to consider disclosure and dialogue, and we have to consider educational and personal development. Challenging stigma on an organizational level includes training and education, outlets for feedback, and hiring people who have shared struggles with clients. Finally, on challenging stigma on a community level includes participant advisory boards, awareness campaigns, policy and advocacy, and events. By following this model, we can help create more meaningful networks and communities of healing. Furthermore, meeting people where they're at during their journey to recovery, along with providing culturally sensitive resources, will result in gradually eliminating the obstacles that Arab American DEC may face when accessing services. What are the 3 major types of trauma? Now we are going to expand on different types of trauma and events. There are 2 types of incidents, an intentional incident and an unintentional incident. Intentional injuries are injuries resulting from purposeful harmful actions upon oneself or others. Examples of intentional injuries are mass violence, like a school shooting, sexual assault, rape, or terrorism. Unintentional injuries are harmful acts that occurred without any goal or desire to damage oneself or others. Examples of unintentional injury include poisoning, suffocation, drowning, burns, or a hurricane. Note that these examples are being talked about in unintentional terms, such as a newborn being rolled over on and suffocated when sleeping in the same bed as the parents. There are 3 major categories of trauma: primary, secondary, and tertiary. Primary trauma occurs when an individual is exposed to or witnesses a traumatic event in response to the event with extreme fear, horror, or hopelessness. An example of primary trauma would be an individual who tests positive for COVID-19. Secondary trauma is exposure to a traumatic event by indirect means. The survivor's recollection of the traumatic event may result in the development of symptoms that closely mirror post-traumatic symptoms. Secondary trauma may also be triggered when a healthcare professional represents the event to a survivor emotionally or cognitively. An example of secondary trauma would be a loved one testing positive or passing away due to complications related to COVID-19. Tertiary trauma occurs when an individual has a relation to those affected by primary or secondary trauma and therefore becomes overwhelmed by fear when they remember the traumatic event. An example of tertiary trauma is being overwhelmed by the COVID-19 cases on the news. I went through a tertiary trauma as a result of the recent explosion that had affected Beirut. My maternal grandmother and one of my aunts had resided in Beirut, Although no one from my family was hurt, I kept thinking of the families that lost their loved ones, and having to see the aftermath of the explosion on television for some weeks was extremely overwhelming for me. The graphic on the right is an image of the trauma continuum, which is a conceptual model to distinguish between shock, trauma, and stress states. It recognizes that each state activates a different part of the brain, different parts of the nervous system, and evokes different post-traumatic responses and involves different orientations to time. This is something to keep in mind when discussing the potential weight or impact of various forms of trauma on depth. I'm going to give 30 seconds for all of you out there watching to think about this question. Which of the following is an example of secondary trauma? Hearing that your friend got into a car accident and being afraid to drive, feeling anxious about traveling outside of the state after hearing about COVID-19 cases, being strangled during an altercation with an intimate partner, all of the above. And the correct answer is A, hearing that your friend got into a car accident and being afraid to drive. So the example of secondary trauma would be answer A, because the individual was indirectly impacted by the traumatic event, which made the person afraid to engage in normal behavior. Answer B is an example of tertiary trauma, because the person learning about someone else's violent encounter shaped their perception of risk and concern about traveling outside of the state during COVID-19. Answer C is an example of primary trauma, because the person was directly harmed during the event. If we go back to the trauma continuum, each answer could fall under a different type of trauma depending on the frequency of the incident, and injury being intentional or unintentional can also influence how a person experiences a traumatic event. For example, answer A can also be secondary trauma with impact of type 3 trauma, which is pervasive. Now we are going to transition into ACEs, and specifically signs and symptoms of anxiety by age group. ACEs occur as a result of trauma that children are exposed to before the age of 18. ACEs encompasses all forms of child abuse, in addition to incarceration, domestic violence, and substance misuse. One thing to note is that the ACE scores don't tally the positive experiences in early life that can help a child build resilience and protect a child from the effects of trauma. Having a grandparent who loves you, a teacher who understands and believes in you, or a trusted friend that you may confide in may mitigate the long-term effects of early trauma. However, according to the National ACEs study by Kaiser, a child with an ACE score of 4 or more is at increased risk for detrimental behavioral, physical, and mental health conditions. Building bonds between people who have undergone similar adverse experiences can be a source of healing. Expanding social supports can help drug-endangered youth become more encouraged to seek resources and services they need. These bonds can also provide a safe space for youth to express themselves freely without fear of being stigmatized. I would just like to note that the difference between social support and trauma bonding. Trauma bonding occurs as a result of the ongoing cycles of abuse in which the intermittent reinforcement of reward and punishment creates powerful emotional bonds that are resistant to change. One major risk among drug-endangered children is forming irresistible connections with facilitators of violence and/or individuals who they have a shared experience with. Although having things in common is a part of developing relationships and forming connections, it can be dangerous when someone is consumed by their trauma so much that they are not open to healing. This can turn into an interpersonal risk when a deck is drawn to or draws people into their trauma. To prevent ACEs, we have to interrupt toxic and structural conditions that impact sociocultural norms, community, family, and the child. These may include stigma, removing a child from an abusive environment, changing policies that prey on low-income communities, and combating policing practices and more. Now we are going to go through signs and symptoms of anxiety during COVID-19 for children in the following age groups. Anxiety is a good indicator that there may be unhealthy stressors taking place at home. For children ages 4 to 7, you may notice that the child is bedwetting, has separation anxiety, and more frequent temper tantrums. For ages 7 to 10, the child may show greater concerns for older family members or may be more irritable and may be in need of an age-appropriate conversation around COVID-19. For children ages 10 to 13, they may experience difficulty completing academic work, display avoidance, have a drop in grades, and are less likely to express their fears and anxieties to their family out of a concern to not make things worse based on their perception. For children 13 to 17, a common sign is a lack of energy, a lack of or loss of interest in hobbies, withdrawal from family, changes in eating and sleeping habits. Quite often, children are coached not to talk about abuse. Many families in the Arab American community warn their youth that, or tell their youth that whatever happens in the house stays in the house. So children may get really good at hiding trauma because they are concerned about the consequence. As an ally, there are things we can do to address their concerns and make them feel safe disclosing. 1, we should welcome all questions. Sometimes children will hint at the problem indirectly. Also look for cues. Do they tighten up when certain people are mentioned or around? Also reassure them without promising that you can resolve an issue, and focus the conversation on prioritizing their safety get support, and always have resources on hand in case it requires an immediate response. We are going to get into coping strategies next. For each age group, I'm going to highlight key coping strategies. For children ages 4 to 7, it's important to establish new routines and explain why you are establishing these changes. Children in this age group are learning how to socialize with peers, and sheltering in place has changed how that will happen. Many kids have a hard time accepting this change, but don't underestimate how much they understand. So this picture is one of a young girl in a video that went viral. She is frustrated with the shutdown that occurred as a result of COVID-19, and she talks about her frustration with not being able to go to her favorite places, such as McDonald's, and not being able to play in the play area. So she understands, but she tells her caregivers that she understands that this is to keep people safe, and her caregivers do a great job of reassuring her by including her in their safety plan and reassuring her that the shutdown is only in place to keep people safe and that it won't last forever. For kids ages 7 to 10, this is when most kids like to hug and play. It is key to talk about the importance of social distancing and defining wellness. For children ages 10 to 13, this is a time when they're beginning to question and challenge authority. This is when they're becoming more aware about if your words match your actions. This is also a time when they're developing their own opinions. It's important not to dismiss their struggles, especially with the changes to their social life with remote learning. For children ages 13 to 17, aka Generation Z, they are all about social connection. Be sure to encourage positive ways to connect. Many coalitions and youth groups are online now, and social media is a great place to facilitate connections and learning opportunities that keep this age group focused on the future. As far as creating a trauma-informed distance learning environment, I would like to highlight the importance of creating ways for children to safely disclose. Teachers can let students know that they can use the chat to privately share concerns. You can even assign the TA to manage incoming messages or to initiate the contact with the child at risk. Additional ways for educators to help students cope include facilitating a dialogue around how students feel about not being able to attend school in person, realizing that not all students' experiences are universal. Some students may be more heavily impacted by the pandemic than others. This impact may hinder their ability to complete assignments in the time allotted to them. Sharing both challenging and positive moments from the day, reaching out to students and addressing any safety concerns they may have. These concerns may range from fears about the virus to financial struggles and food insecurity. And finally, incorporate connectedness through creating opportunities for engaging activities into online lesson plans and take-home packets. Additional activities that can be done to help children cope include a feelings chart to assess how students are feeling using emojis. This is a good icebreaker. Kids typically select how they feel. Breathing exercises, which is something you can facilitate over Zoom, and having youth participate in drawing or writing exercises using questions that might draw out emotions. Additional groups of students who need more support from educators include students who have family members who are at risk for contracting the virus, students who have a caregiver who has a career in healthcare and is at risk for being exposed to the virus, students who are under less supervision due to a caregiver's work, and effective ways for educators to interact with students are contacting caregivers and explaining the supports they need, the supports they offer within the learning environment, setting up individual meeting times with students through phone conferences or Zoom, and facilitating a connection between school mental health professionals and the students along with their families. Word choice is everything when connecting with and communicating with trauma-exposed children. Sometimes drug endangered children adopt terminology that is stigmatizing, self-blaming, and harmful. Equip children with information that will support them with developing language to define their experiences. Be aware of their stress level. The responder should not take offense if communication is unwanted. Sometimes it's better to wait until the situation has calmed down. And some things to note include understanding that each family requires different levels of support, as rates of domestic violence have increased, which can cause feelings of isolation and vulnerability to increase during the pandemic. Offering resources to help caregivers and educators develop a clear understanding of the consequences and resilience and impact of students who have experienced trauma. Now I have a few recommendations for advocates who are struggling during COVID-19. Engage in self-care activities, as it is important to take care of one's own mental health before taking care of others. Reflect on the issues that you are struggling with and create a plan for navigating them. Don't dismiss your own adversity. Work on letting go of the emotional attachment to circumstances that are outside of your control. We all have a role in addressing and combating systemic and interpersonal trauma, and although we should always prioritize the safety of the child, remember caregivers may be in danger too. Caregivers can also be victims and survivors of structural and community violence and may need to unlearn unhealthy behavior and relearn how to be a caregiver if they have been away or if they have unaddressed unaddressed behaviors or mental health conditions, behavioral or mental health conditions. It is also important to think about the family, especially if the child thinks or desires to protect their caregiver, even if the caregiver is the one inflicting the violence. So now I'm going to read this exercise, and I encourage all of you watching to please think about effective ways that you would address this situation. Rima is 15 years old and is a first-generation American. She was born to Lebanese Muslim immigrant parents who came to the US when Rima was 3 years old. Her parents speak limited English. She is bilingual and the oldest of 3 children. Rima is a student in your class who has perfect attendance. After the pandemic, you notice that Rima is absent from class for a week. You decide to schedule a private Zoom call with her and find out that she has been struggling with substance disorder after her parents recently divorced and that her father abused her mother. He tells you that she is hiding her substance use from her family. In what ways would you prioritize Rima's safety while maintaining cultural sensitivity? I urge you all to please think about that. And please think about ways to handle similar situations. Thank you. I've also included a video of community perspectives in the Arab and Muslim community, which I will share shortly.
My grandfather was a very well-known imam, probably one of the most well-known to date in the U.S. Early on, substance abuse wasn't really talked about in my family. It was never an issue before my aunt really kind of dealt with it. And my aunt was the daughter of my grandfather, so if you can imagine just the pressure that the family felt initially to try and keep such a horrible, ugly secret under wraps.
People really find it difficult to accept that there is such a crisis in their household. And they are afraid that people are going to talk about the family and the fact that they have failed as parents. So we are working with the community members to try to address this issue, that there is no stigma, or at least culturally they should overcome it. And the sooner they deal with it, the better it is, rather than brush it under the carpet and then wait for it to disappear, which is not going to happen.
In the Arab community in particular, they have a concept called aib. Aib means shame. So when you talk about drugs, fornication, these things in the sermon, it's like, no, don't say that, but you should say that. And Prophet Muhammad, peace be upon him, was very open, and he spoke to everything, because the Quran speaks to everything in every condition. So for myself, I choose to take the lid off. We're not it's aib or shameful if I don't talk about it.
What will happen if you don't do it? Not only you have religious responsibilities, do you think that the child is going to cure himself or herself? They are incapable of doing anything. A child that walks half asleep, what do you expect from him? You are the one that has to grab his hand or her hand and guide them through. So it's better to take case by case on an individual basis and refer it to the expert here at Access and say, okay, these are your sisters and brothers within the community. They are expert in the field. They are sensitive to to the culture. Why don't you go and see them?
So if you're struggling, there's so many different resources that you can use, to help with this addiction or your alcoholism. So don't be embarrassed or ashamed. Go get the help you need. Just seek help, and somebody will help you get through this. There's a lot of people who have been in the same situation who will help you.
Addiction is a disease. It does not discriminate. Here at Access, we have culturally sensitive staff that can understand the Arab American culture and how it's difficult for our community members to take the first step and seek out help.
So 10% of our society has a substance use disorder. Because of stigma, many don't seek the help that they need. But those that do seek the help, I want you to know that the help is there for you. No matter your culture, your ethnicity, or where you live, you are worth seeking the help that you deserve.
If you feel or think that you have any addiction issues, please reach out for help. There are many providers in the community now understand addiction and ready to help.
If I could give advice to the elders in the community, I would tell them that you have to put down cultural baggage and use the book, the Quran. The Quran has a quality, it's called shafa. Shafa means a healing. The Quran is designed to act as a medicine, whereby once you ingest it in your heart and your mind, and you earnestly trying to change, then you will see life coming back to a heart that is dead. And so I would tell them that you have to speak the truth, no matter how embarrassing it may be. But your only chance to save many is to speak to those personalities while they are in your face.
Some companies still have and their
Before we conclude, I would like to share some resources. The Child Abuse Library Online, or CALIO, is a service of the National Children's Advocacy Center developed as a resource collection for professionals working in fields associated with child abuse. Some behavioral health resources include the Detroit Wayne Integrated Health Network 24/7 helpline, the MDHHS 24/7 Stay Home, Stay Well initiative text line, the National Suicide Prevention Lifeline, which also runs 24/7, the Michigan Warm Line, and the Disaster Distress 24/7 helpline. Access, or the Arab Community Center for Economic and Social Services, has been serving the community for more than 47 years. Founded by a group of dedicated volunteers in 1971 out of a storefront in Dearborn's impoverished South End, Access was created to assist the Arab immigrant population adapt to life in the United States. Today, Access is the largest Arab American community nonprofit in the United States, with 11 locations and more than 120 programs serving Metro Detroit. Access offers a wide range of social, economic, health, and educational services to a diverse population. A local program I would like to highlight is the Detroit Recovery Project, DRP. DRP strengthens, rebuilds, and empowers communities affected by drug and alcohol addiction and other underserved populations. DRP supports individuals in identifying and resolving barriers to achieving a healthy and productive drug-free lifestyle. Additionally, DRP offers peer-to-peer support services for individuals exiting treatment, individuals in long-term recovery, and support to their loved ones. For more information, visit recoveryfordetroit.com. Feel free to register for more trainings at 313hope.eventbrite.com. We have a lineup of great topics and facilitators. Topics are updated every month, and we add new dates all the time. Feel free to connect with us via social media. Our email address is 313hope@detroitmi.gov, and you can follow us on Instagram, YouTube, and Facebook. Thank you everyone for joining, and I appreciate you for watching this. Thank you.